Let's now turn our attention to a discussion of the development of the heart, and that will subsequently lead us to a discussion of congenital heart disease, abnormalities in development. Heart begins its development as a simple tube, what's called a heart tube. And that's what's being represented in this first diagram. That heart tube is established as a ventral midline blood vessel in the chest at the 4th week of development. As soon as we have those lateral body folds that establishes a ventral wall to the embryo, as soon as those lateral body folds fuse in the ventral midline, right at that point we already have a tube, a blood vessel, running behind that ventral body wall in the chest, and we call that the heart tube. So the heart tube is really just a blood vessel. And the direction of blood flow through that blood vessel is from caudal to cranial, in that direction, as is shown in this arrow here. That is the direction of blood flow, from caudal to cranial. So if we have established that that's the direction of blood flow, and then if we accept the fact that it's this middle part of the tube that I'm circling here that's going to become the heart, well, that immediately tells you that the lower part of the tube that's carrying blood to the heart must become veins. And that also means that the upper part of the tube that's carrying blood away from the heart, that's going to become arteries. So we know that this part of the tube will become veins, this part of the tube will become arteries, and this part of the tube will become heart. And now we can become a little bit more specific, saying that the part of the heart into which the veins drain is going to become atrium. So this part's going to be atrium, and then from atrium it'll go to ventricle, and then from ventricle to arteries. So we're saying that this heart tube will develop in such a way that this becomes veins, this becomes atrium, this becomes ventricle, this becomes arteries. And the names are suggestive of that. This part is called the sinus venosus, veins, venosus. We're calling this primitive atrium and primitive ventricle. We'll see why that's true in a few moments. And then let's just skip bulbous cordus for a few moments, and this is called truncus arteriosus, arteries. This is going to become arteries. Now, in this next diagram, what we see happening is that parts of this heart tube are expanding, are getting larger. The parts of the heart tube that will become the chambers of the heart have to become larger than the parts of the heart tube that will become the veins and arteries entering and leaving the heart. So this part is going to get larger, and we can see that happening here. The part that's ventricle has gotten larger, the part that's atrium has gotten larger. But now we have to ask the question of how did it get larger? And there are a couple of mechanisms involved, but one of those mechanisms is worth talking about because it explains some adult structure. A way that these chambers can get larger is by incorporating the nearby blood vessels into themselves. In other words, if this atrium wants to get larger, if it takes some of this sinus venosus that's right next door and incorporates it into itself, then the atrium will be larger and the sinus venosus will become part of that atrium. So that's what's happening here. Some of the sinus venosus is getting incorporated into the atrium, thereby making the atrium larger. Similarly, if the ventricle wants to get larger, a way it can do that is by taking some of its neighboring vessel, which is the beginning of this truncus arteriosus, which has the name bulbous cordus, and incorporating it into itself. So the bulbous cordus gets incorporated into the ventricle, making the ventricle larger. So what we're saying is that what will become the adult atrium was partly the primitive atrium and partly the sinus venosus that got incorporated into it. What becomes the adult ventricle was partly the primitive ventricle and partly the bulbous cordus that got incorporated into it. Well, we can recognize these different parts for the following reason. The parts of the heart that were the original chambers, the primitive atrium and primitive ventricle, have an inner surface, a luminal surface, that is trabeculated, roughened. It has ridges of muscle. The parts of the heart tube that were originally blood vessels, the veins and the arteries, have smooth luminal surfaces. So when we incorporate the smooth surfaced bulbous cordus into the rough surfaced primitive ventricle, we'll end up with a larger ventricle, some of which is rough-walled, some of which is smooth-walled. And when we take this smooth-walled sinus venosus and incorporate it into the rough-walled primitive atrium, we'll have a larger atrium, some of which is rough-walled, some of which is smooth-walled. So when we look at the interior of the adult heart, as is indicated on this chart, what we can see here is that the rough-walled, the trabeculated parts of the right and left atria are the parts that came from the primitive atrium. The trabeculated or rough-walled parts of the ventricles, right and left, is what came from the primitive ventricle. But the smooth-walled part of the ventricle wasn't the original ventricle, it was the bulbous cordus that got incorporated. And similarly, the smooth-walled part of the right atrium was originally the sinus venosus that got incorporated. So the differences in the appearance of different parts of the interior of the chambers is directly related to its embryonic development. Now, one additional thing is happening in this picture. This heart tube that starts off as a straight tube going from caudal to cranial is going to fold. Now, just to give you the orientation, imagine that you're looking at this from the left lateral side. You're standing to the left of the embryo, looking at the heart tube. This is caudal, this is cranial, this is anterior, this is posterior. And what we see has happened is that this straight tube has folded like that into an S-shaped curve. The S is lying on its side, but it's an S-shaped curve. So that means that while we initially had the arteries above the heart and the veins below the heart, we now have the arteries coming out the front of the heart and the veins going into the back of the heart. It also means that while we originally had the atrium below the ventricle, we now have the atria above the ventricle because of that folding upon itself. And when we look at the adult heart, sure enough, we see that the atria are above the ventricles. We see that the arteries are indeed leaving from the front wall of the heart, and the veins, as you can see here and here and here, are entering into the back wall of the heart. So exactly what we would expect from that heart folding is exactly what we see. We'll turn our attention now to a discussion of the circulatory changes at birth, and we'll start by looking at the circulatory pattern in the prenatal individual and then compare that to what happens postnatally. So the key point to remember when we think about prenatal circulation is to remember that the source of oxygen for this blood is the placenta, not the lungs. So therefore, the blood that's going to the placenta is going to be deoxygenated, and the blood coming from the placenta will be oxygenated. So let's start at that point. The blood going to the placenta will be going out through the umbilical arteries. I'll illustrate that in this purplish shade to indicate that it's partially deoxygenated blood. It goes out through the umbilical cord to the placenta, at which point it gives up its CO2, picks up oxygen, comes back through the umbilical vein as oxygenated blood. So that oxygenated blood goes up the umbilical vein, continues to the continuation of the umbilical vein, which is called the ductus venosus, and will eventually drain into the inferior vena cava. But before we get to that, let's think about what's coming up through the inferior vena cava. The venous return from the lower part of the fetus or embryo, in other words, from the lower limbs and the pelvis, is coming up the inferior vena cava, and that is deoxygenated blood. So we have oxygenated blood in the umbilical vein, which is going to join this deoxygenated blood in the inferior vena cava, and when they meet, they will mix together and will end up with a level of oxygenation somewhere in between those two. So I'm demonstrating this in the sort of a light purple, indicating it's partially oxygenated blood. And that's what gets into the right atrium. At the same time, we have blood coming through the superior vena cava coming to the right atrium, And that blood is simply the venous return from the upper limbs and the head and neck. And so that's deoxygenated blood. So interestingly, prenatally, we have two different kinds of blood entering the right atrium. Through the IVC, we have somewhat oxygenated blood, and through the SVC, we have deoxygenated blood. Now, interestingly, when they come into the right atrium, well, one might think that they simply sort of mix together like in a mixing bowl, and we end up with some intermediate level of oxygenation. That's not really what happens. What actually happens is that these two flows of blood flow past one another, and they end up going to different places. So let's follow them one at a time. Coming up from the IVC, we said we have somewhat oxygenated blood, a mixture of umbilical venous blood and IVC blood. When that blood comes into the right atrium, it continues through the right atrium, through the foramen ovale, and then into the left atrium. And then from the left atrium into the left ventricle, and then from the left ventricle out to the ascending aorta. So that's the IVC blood. The SVC blood, when it comes into the right atrium, for the most part, it does not go through the foramen ovale. As you can see, if you look at the schematic, you would have to sort of make a U-turn for it to go through the foramen ovale. So blood obviously doesn't do that. It follows a fairly straight path and goes from the SVC through the right atrium, through the tricuspid valve, and goes into the right ventricle. So even though they both pass through the right atrium, they end up going different places. The SVC blood goes to the right ventricle, the IVC blood goes to the left atrium, and then out the left side of the heart. This deoxygenated blood that ends up in the right ventricle then leaves the right ventricle through the pulmonary trunk. When it gets to the pulmonary arteries, very little of it goes out the pulmonary arteries because, as you recall, there's a very high vascular resistance in the pulmonary circuit, so very little blood can get out to the pulmonary arteries. And so this blood, for the most part, shunts out of the pulmonary circuit through this little path here known as the Ductus Arteriosus, which connects the pulmonary circuit with the aorta. And so this blood shunts from the pulmonary circuit through the ductus arteriosus into the aorta, at which point it now meets the blood that's already in the aorta, having come up the ascending aorta from the left ventricle. But this is much more oxygenated than this. They now mix together to something in between, and that's what continues on down the descending aorta through the thorax, abdomen, and onto the rest of the body. So we see that the blood in the ascending aorta and in the descending aorta are not the same. The ascending aorta blood is much more oxygenated than the descending aorta blood because at this point where the ductus arteriosus enters the aorta, we've mixed together the two bloods into this intermediate level of oxygenation. That raises a fairly obvious question, which is, why is the design such as to prevent mixing here? We keep these two flows of blood, the IVC blood and the SVC blood, separate and send them in separate directions and not have them mixed together if we're only going to have them mixed together anyhow at this point. And the answer to that question is seen here in the takeoff of these three blood vessels from the aortic arch. We can see that these three blood vessels, the brachiocephalic trunk, the left common carotid, and the left subclavian, are branches of the aortic arch that come off the aortic arch before the ductus arteriosus enters the aortic arch, which means that it's only this blood in the ascending aorta that can fill those three vessels. So those three vessels are fed by the more oxygenated IVC blood, and then things don't mix together until we get past the left subclavian, so that the descending aorta and the rest of the body gets the less oxygenated blood. Of course, what these three blood vessels have in common is that they are all providing blood supply to the brain. Certainly the carotids on the right and left side supply the brain. And remember that the subclavians, even though we think of them first and foremost as the blood supply to the upper limb, remember that the first branch of the subclavian is the vertebral artery, so the subclavians also provide blood supply to the brain. So the blood supply to the brain is restricted to the more oxygenated blood. The blood supply to the rest of the body gets fundamentally what's left over. So that's the status of the prenatal circulation. That's how this fetus lives until birth. Let's think about the changes that occur at birth. The first thing we know, of course, is that at birth, the umbilical arteries will close down. The adult remnant of the umbilical arteries is what ends up being called the medial umbilical ligaments. Of course, the umbilical vein closes down, and the adult remnant of what was called the umbilical vein is what we now call the ligamentum teres, or the round ligament of the liver. We'll talk more about that when we get to the abdomen. With the closure of the umbilical vein, that of course means there's no blood that can get to the ductus venosus, so the ductus venosus closes down, and the adult remnant of that is called the ligamentum venosum. Not very important. But what that means is that the blood that's in the IVC gets to the right atrium without mixing with any blood coming back from the placenta, because we no longer have a placenta. So the deoxygenated blood of the IVC gets to the right atrium, and that means it's the same as the SVC blood, which gets to the right atrium. So now postnatally, what comes into the right atrium, regardless of whether it's SVC or IVC, is the same deoxygenated blood. We've already said that at birth, as a result of the reversal of the pressure gradient, we get a closure of the foramen ovale. We know that the fossa ovalis is the adult marker to indicate where that foramen ovale was. But with the closure of the foramen ovale, that means that there's only one pathway out of the right atrium, and that is to the right ventricle. So that's where the blood goes, to the right ventricle. Leaving the right ventricle, we go into the pulmonary trunk. And now, because of the expansion of the lungs and the reduction of pulmonary vascular resistance, the blood from the pulmonary trunk can in fact go out to the pulmonary arteries. And in addition, the ductus arteriosus closes, and the adult remnant of that is called the ligamentum arteriosum. So we have closure of the ductus arteriosus, and the blood goes out through the pulmonary arteries, gets to the lungs, picks up oxygen, and now comes back through the pulmonary veins as oxygenated blood comes into the left atrium, to the left ventricle, and then out the left ventricle into the ascending aorta, which then continues around the aortic arch into the descending aorta and out to the body. So now postnatally, the blood in the ascending aorta and the descending aorta is the same, and the entire body is getting the same oxygenated blood, as opposed to there being different levels of oxygenation for the brain and the rest of the body. So those are the key changes at birth. Now, we haven't said anything about this ductus arteriosus other than to say that it closes. We said that it served as a shunt prenatally, with the shunt going from the pulmonary circuit to the aorta. Let's take a look at that. Here we have the ductus, there's the pulmonary trunk, here's the aorta. This arrow represents the direction of flow prenatally, with the flow going from the pulmonary to the aorta, following the pressure gradient that we have prenatally, a right to left pressure gradient. After birth, when that pressure gradient reverses, the flow through the ductus arteriosus will be left to right. So the reversal of the pressure gradient, while it was responsible for the closure of the foramen ovale, the reversal of the pressure gradient does not close the ductus arteriosus. It simply changes the direction of the shunt and converts it from a right to left shunt into a left to right shunt. Which means that if the ductus arteriosus remains patent, the defect known as patent ductus arteriosus, that means that that defect will be a left to right shunt, which means it is not cyanotic. So patent ductus arteriosus is a non-cyanotic defect. But that still leaves us with the question of how does it close? And the mechanism for its closure is interesting. There are fundamentally two parts to the mechanism. This ductus arteriosus is really just a fancy name for a blood vessel. It's an artery. It's an artery that connects two other arteries. And like any other artery, it has smooth muscle in its wall, and the smooth muscle is arranged in a circular fashion so that contraction of the smooth muscle constricts the lumen, narrows the lumen. What's special about the smooth muscle in the ductus, and oftentimes you'll hear it referred to as ductal smooth muscle, is that it has the capacity to contract a lot. It can contract so much that it will not only constrict the ductus arteriosus, but it will completely occlude the ductus arteriosus. So closure of the ductus arteriosus is a result of contraction of the smooth muscle of the ductus arteriosus. Since smooth muscle contracts slowly, that means closure of the ductus arteriosus is a gradual process. In contrast to the closure of the foramen ovale, which occurs almost immediately at birth as a result of the immediate reversal of the pressure gradient, closure of the ductus arteriosus takes hours. And usually it's closed within the first 24 hours, sometimes as long as 48, but typically within the first 24. But it's a gradual closure because of the slow contraction of the smooth muscle. But that still leaves us with the question of how does the smooth muscle know to do it at that time? And the answer to that is that the ductal smooth muscle responds or is stimulated by oxygen tension. When the oxygen tension in the circulating blood rises, which occurs when the baby starts to breathe, and when the reversal of the pressure gradient causes this oxygenated blood to be shunted right through the ductus to bring it into close contact with the wall, with the ductal smooth muscle, that increased oxygen tension stimulates the smooth muscle to contract. At the same time, there's an inhibitor to the contraction of that smooth muscle, an inhibitor that it inhibits the stimulation caused by the oxygen, and that inhibitor is prostaglandin, circulating prostaglandin. So what occurs is that at about the time of birth, and it's important to understand that this is really a developmental or a timed process, at about 9 months of development, levels of circulating prostaglandin drop. So that means that at around the time of birth, we have increased oxygen saturation, stimulating the smooth muscle, and decreased prostaglandin, so we've decreased the inhibitor. So between increasing the stimulator and decreasing the inhibitor, between the two of them, the ductus arteriosus closes normally. So we're saying that the reversal of the pressure gradient changes the direction of flow through the ductus arteriosus, changes it from a right to left shunt into a left to right shunt. And then we're saying that the increase in oxygen saturation plus the decrease in levels of circulating prostaglandin lead to the closure of the ductus arteriosus. Understanding that mechanism allows us to clearly understand why the incidence of patent ductus arteriosus is substantially higher in preterm infants than it is in full-term infants. Because in preterm infants, oftentimes the lungs are not fully developed, and so the transport of oxygen across the alveolar membrane is reduced, so the circulating blood is less oxygenated, the child is hypoxic. And because the levels of prostaglandin decrease at around 9 months of development, if the baby is born before that, prostaglandin levels are still too high. So between the oxygen being too low and the prostaglandin being too high, it's not a surprise that oftentimes these premature babies do not get closure of the ductus arteriosus. But recognizing that mechanism, that means that we can cause closure of the ductus arteriosus by addressing both of these elements. Because of the hypoxia, we're going to want to provide exogenous oxygen anyway to reverse the hypoxia, so we're going to raise the oxygen level. And then we can lower the prostaglandin levels by inhibiting the synthesis of prostaglandin. using a prostaglandin synthetase inhibitor, indomethacin being the most commonly used. So with the administration of oxygen and indomethacin, we raise oxygen levels, we lower prostaglandin levels, and that typically will lead to closure of the ductus arteriosus in these premature babies. But let's think about the flip side of that, the reverse of that. If we think back for a moment to what we talked about when we talked about transposition of the great arteries, we said we needed an explanation for why these babies were alive. And we said the explanation was that there were other defects, mixing defects, that were helping to keep the baby alive. That's why the baby was alive, because there was mixing of blood through these defects. Certainly, one of those mixing defects was a patent ductus arteriosus, because these kids are very hypoxic. So, in that case, if we think about it, if we address the hypoxia by administering oxygen, that oxygen is going to cause closure of the ductus arteriosus, which is likely to lead to the death of the child. And so, since we want to be able to administer oxygen, we have to increase the levels of prostaglandin to prevent closure of the ductus arteriosus. So exogenous prostaglandin is given to allow the administration of oxygen while keeping the ductus arteriosus patent, so that the mixing defect that is keeping the child alive is retained. So what we're saying is that if we want to close a patent ductus arteriosus, we can inhibit prostaglandin synthesis, and if we want to maintain a patent ductus arteriosus, we can administer exogenous prostaglandin. Normally, after the ductus arteriosus is closed, what's left is called the ligamentum arteriosum, and it's a landmark that can be identified in the adult but no longer has a functional significance. So to summarize, what we're saying is that the structural changes that occur at birth is that we get closure of the umbilical arteries, and the adult remnant is called the medial umbilical ligaments. We get closure of the umbilical vein. The adult remnant is the ligamentum teres. We get closure of the ductus venosus. Remnant is ligamentum venosum. The pressure reversal closes the foramen ovale. We have the marking of the fossa ovalis to tell us where that was. And now we have the closure of the ductus arteriosus, with the ligamentum arteriosum being the adult remnant of that.